Well, good afternoon, everyone, especially those on the East Coast, and good morning to those on the West Coast. I'm John Carney. Thanks for joining us at the Center for Practical Bioethics for this live webinar in our first of a four-part series exploring the ethical, equity, and justice issues in emergency authorization for COVID vaccine. We begin this series by examining the science and challenges in implementing the largest public health response to a global pandemic in the history of humankind. This opening session, entitled Safety and Efficacy in Emergency Authorization, Getting It to Those Who Want It and Responding to Those Who Don't, features two national ethics experts on our panel, along with the Center board member, Darren D'Agostino, Executive Dean at Kansas City University, who will serve as moderator for our robust discussion following the formal remarks. My colleague, Matthew Piecka, will serve as technical support to the panelists and to the attendees. Christine, Kathy, and Darren, thanks so much for being with us today. Darren, it's all yours.
Thank you, John. I am Darren D'Agostino, and I'm the Executive Dean and Vice Provost for Health Affairs at Kansas City University. And I'd like to again welcome everybody to this very timely and important ethical discussion around vaccinations. With that, I'd like to introduce our two expert panelists to help guide our discussion today. Dr. Christine Grady is a nurse bioethicist and a senior investigator currently serving as the chief of the Department of Bioethics at the National Institutes for Health and Clinical Center. Her research focuses on the ethics of clinical research, including informed consent, vulnerability, study design, recruitment, and international research ethics, as well as ethical issues that nurses and other healthcare professionals face. Christine has authored more than 175 papers in the biomedical and bioethical literature and authored or edited several books, including the Oxford Textbook of Clinical Research Ethics. She served from 2010 to 2017 as a commissioner on the President's Commission for the Study of Bioethical Issues. She is an elected fellow of the Hastings Center and the American Academy of Nursing. She is a senior research fellow at the Kennedy Institute of Ethics and also an elected member of the National Academy of Medicine. Dr. Grady shares her vast experience through service by committing time to editorial boards, consultations, and reviewing research that others are performing. She holds a BS in nursing and biology from Georgetown University and an MSN in community health nursing from Boston College, and a PhD in philosophy from Georgetown University. Kathy Kenlaw is an associate director of the Emory Center for Ethics, and she is the lead ethicist at Emory Healthcare. She serves as chair of the Emory University Hospital Ethics Committee, is an assistant professor of pediatrics at the Emory School of Medicine, and also directs the Healthcare Ethics Consortium, a network of healthcare systems in the Southeast. Kathy directs the integration of clinical ethics into the Emory School of Medicine's curriculum and residency programs. She completed 8 years of service as a board member of the Georgia Composite Medical Board and served as a member of the Committee on Ethics and Professionalism of the Federation of State Medical Boards. She also served as a member of the CDC Ethics Subcommittee of the Advisory Committee to the Director. Kathy has brought ethical analysis and guidance to legislators in multiple areas influencing policy and process, including the Georgia Advanced Directives for Healthcare in 2007. In 2010, the revision of the Georgia Informed Consent Law, with particular attention to the consent process for those who lack decision-making capacity, and the Georgia Pulsed legislation in 2015, which gives emergency medicine personnel immediate, actionable, specific medical orders to follow. Kathy received her Master's of Divinity with a focus on religious ethics and bioethics from the Chandler School of Theology, completed a bioethics internship at the National Institutes of Health, Offices of Bioethics, and a fellowship in perinatal ethics through the Emory School of Medicine. She's also completed certification as a healthcare ethics consultant. Please welcome our panelists for your discussion.
Thank you very much. Yes, thank you.
I think I will go first, so I'm going to share my slides, and then hopefully, there we go. Can't talk and do slides at the same time. Now I can talk. Okay, so as you heard, my name is Christine Grady, and I'm from the NIH, and what I'm going to share with you today are my views, not those of the NIH. I thought it would be helpful to start by recognizing that in vaccines, or with vaccines, there are ethical issues at sort of every step of the way. There are really vexing ethical challenges in vaccine development and testing. There are ethical challenges in vaccine allocation and distribution, and there are ethical challenges in use and social acceptability of vaccines. And these are not, of course, limited to COVID, but I think form the backdrop for how we understand some of the issues in COVID. In the short time that I have with you, what I thought I would do is say something about the COVID vaccine research and warp speed with which it was done, what emergency use authorization is and how what its implications are, and how both the research and the EUA relate to both acceptance and trust of vaccines. And I know Kathy's going to talk about allocation and distribution. So first, to start with, vaccine development and testing is has tons of ethical issues. So one of the things is the goals of vaccine development in any case are to find a vaccine that is extremely safe and extremely effective so that it can be given to, you know, millions of people, usually across a wide spectrum of age and health. The usual trajectory for developing a vaccine is quite long and intense and expensive. Goes from first understanding what the microbe is and what the natural history of a disease is, to testing something in the laboratory, then in a preclinical testing, then in humans, until it's finally found safe and effective enough to be useful. There are scientific and ethical decision points all along the way in terms of doing vaccine development and testing. Certainly scientific decisions about, you know, what candidates to try to test in the laboratory, what candidates to move forward to animal and human testing, and ethical decisions along the way with respect to when is the data sufficient to move into clinical testing, how should the clinical testing be done, who should be included in that, who is going to be the ultimate beneficiaries of these vaccines that we're testing. And so I think the important question for today's discussion is, how was COVID different? Now, for one thing, and this is kind of a busy slide, but just to walk through it very quickly, you know, this is the preclinical testing, the clinical testing, and the monitoring. And this is a timeline, and the normal trajectory for vaccine development is estimated to be anywhere between 5 and 20 years for most of the vaccines that we have in play. And there certainly are diseases for which we still don't have a vaccine even after decades of research. What's different about COVID is that all of this happened, the same trajectory happened in a very short period of time. And in less than a year, we went from sequencing the virus to having a vaccine that was created, tested in animals, tested in phase 1, 2, and 3 clinical trials, and now is being distributed through an emergency use authorization. So the speed with which this happened is really remarkable, and yet the process, the steps were not any different. Another thing that was different about COVID vaccines is in the normal trajectory, you have manufacturing and scale up of vaccine occurs at the end. So once you have data on efficacy and safety, then a manufacturer might begin to scale up the manufacturing of that vaccine for widespread distribution. In the case of COVID, as you all know, because of the investment put out by Operation Warp Speed on the behalf of the federal government, manufacturers were beginning to develop, scale up, and manufacture large quantities of vaccine before the data were being collected. So that's another thing that's very different, and one that a lot of people have paid attention to. So some of the ethical challenges in this really come down to a few. One is, how do you do vaccine development and testing as quickly and expeditiously as possible without compromising any of the scientific principles or the ethical principles that usually guide research? And that was something that came up over and over again, and there was a lot of public attention to it as well. There were decisions all along the way about how to do this, how to do vaccine testing quickly without compromise. So for example, in the very beginning, there were a lot of discussions about whether or not there was a role for human challenge studies in vaccine development for COVID, or whether we should go with the standard RCT, or whether we should use an accelerated RCT, or whether we should use some other design. Those were huge debates and ethically charged debates. There were lots of interesting decisions made about inclusion. Who should be in a trial of COVID vaccine, knowing that even early on, we knew that people were at higher risk if they were older, if they had certain comorbidities, if they belonged to certain communities of color. And so how to create the operation for the trial so that the representative sample was included. There are and continue to be really interesting questions about how should trials, either that are already in development or in place, or ones that are being planned, how should they look now that we have some vaccines that have shown efficacy? How does that change the ethics of doing a trial? And this is increasingly important, of course, also with respect to doing international trials, recognizing not only global needs in terms of the pandemic, but global needs in terms of the kinds of vaccines that might be available. So many of you might be familiar with this New York Times tracker. I find it really interesting, and it's updated every day. There are a couple hundred vaccines in development, but these are the ones in clinical phases. And just to bring you to two numbers, one is there are 20 in phase 3 trials right now, but a whole bunch coming up. There are 8 in limited use, and the 2 that are under emergency use authorization fall into this category. There are 2 that have been approved, not in the United States, but in other parts of the world, and there are 4 that have been abandoned. So that brings us to the emergency use authorization. Again, as everyone probably knows, there are 2 messenger RNA vaccines, both one by Pfizer and one by Moderna, that were shown to be greater than 90% efficacious in preventing symptomatic COVID. And they were each authorized for emergency use in December of 2020, not on the same day, but both in December. Interestingly, in the last 24 hours, we have now data that's been announced from 2 additional vaccine candidates, and I'm going to say a little bit more about those in a minute, Novavax and J&J. But what is this emergency use authorization? So in the normal trajectory, as we've seen from a different picture, after the phase 3 data is collected, if there's evidence of safety and efficacy, most companies will then submit a biological license application to the FDA in order to get an approved vaccine. But in this case, we have emergency use authorization, which is a sort of new step in so many ways. I think the important realization is that we have never had a vaccine in the United States that was distributed based on an emergency use authorization. So understanding what that means is really helpful in understanding what we're being offered as vaccines. This is a diagram that came from an FDA document. It just gives you a very quickly sort of the process. So the first 2 steps are, there has to be an emergency that then is declared by the Secretary of HHS in the United States. Companies do communicate with the FDA before they're ready to submit an application for an EUA, but once they submit it, then it's reviewed and approved or rejected by the FDA. And this process in the COVID story was very transparent and very public. All of the data were available online, and the vaccine and related biological products advisory committee meetings were also online, streamed online. Importantly, an EUA has an endpoint. So when the emergency is ended, the emergency use authorization will also end. And so it's important for all of us to keep in mind that emergency use authorization, which is allowing for distribution, is very different than licensure, requires different kinds of data, processes, and usually time. One thing from this slide that I just wanted to point out is this bullet here. sorry, that one of the important criteria for authorizing something under an emergency use is that the known or potential benefits of the particular item outweigh the known and potential risks. And that's what was used to determine that the 2 messenger RNA vaccines were approved or authorized under an EUA. Importantly, post-authorization, there's still a lot of attention to safety. And this was just a report from a meeting this week at the CDC Advisory Committee on Immunization Practices had, where they were looking at the safety data after about 23.5 million doses of Pfizer and Moderna had been distributed in the United States. And they found very few serious side effects. There were some deaths in the people who got vaccine, but almost that none of them appeared related. And the common symptoms that occurred in the 23 million people were very similar to what they saw in the clinical trials, in pain at the injection site, fatigue, headache, muscle soreness, and in some people, fever and chills, primarily after the second dose. What about these new data? So this was reported yesterday in STAT about the Novavax vaccine. There are some Novavax trials in the United States. The data that was reported was not from the United States. It was from the United Kingdom and South Africa. And I think importantly, what they reported as preliminary results was that the Novavax vaccine was 90% effective in the United Kingdom, even against the variant that's circulating and dominant there, but less effective, only 49% effective in South Africa against the variant that's there. Of note, the numbers of people in these 2 trials are quite small compared to some of the other studies that from which we have data. Johnson & Johnson, on the other hand, was reported just this morning. And this is an article that I found on CNN Health. I haven't seen the data. I don't think the data are yet public, but this is the announcement. Johnson & Johnson's single shot vaccine, which many people were waiting for, was 66% effective in preventing moderate and severe disease, and 85% effective against severe disease, and 72% effective in the United States. So I think this is going to take a lot of unpacking and a lot of explaining to the American public and to the world publics about what these data mean. I think everybody also knows there are several variants that people are watching very closely. And one of the major concerns about the variants is whether or not the vaccines that are currently under authorization or being tested have efficacy against the variants. And although there's data still coming in, basically the studies that have been done thus far show that against the UK variant, there's some slight diminution in antibodies, but still plenty to protect. Perhaps more serious diminution against the South African variant, but also, again, still some hope that there's still protection and ongoing data being collected about the Brazil variant. And there are likely many other variants. So I want to turn to and actually end with a little bit of a discussion about social acceptability of vaccines. I think one thing that's really apparent to me is that as data emerge and people are confused about what the data mean, that confuses acceptability. Many people, I think it's true that there are many people in the public that don't fully understand how vaccines work to begin with, don't really know about the process of research and development of vaccines and all of the steps that go into it. And they rely on the sort of sound bites that they see in the news about, 90% effective or 80% effective. And then hear lots of other things that are sometimes hard to put together. In this case, in COVID case, we also have a fair amount of vaccine hesitancy. And this is against a background, as probably everyone knows, of long-standing vaccine hesitancy. There's been vaccine hesitancy since the day vaccines were created. And it's ebbs and flows, and it goes with different kinds of vaccines, but there certainly is considerable amount in this case. And in the era of COVID, we also have a huge amount of disinformation. information that is available on social media, sometimes other kinds of media, and also person-to-person kind of communications, information that has no sort of evidence backing it, but is being widely disseminated in certain places about these vaccines. I think it's interesting to look at the data on acceptability, and the data comes in two ways as I see it. One is from surveys of willingness to accept vaccines, and the other is on actual uptake of the vaccines as they've been rolled out. And what we see is that, especially from the surveys, there's about a third of people who, and these are people in the public, it also includes healthcare providers, and lately a lot in the press has been nursing home staff, that at least a third of some of those groups say they are not willing to take the vaccine. There's also a fairly significant group that are unsure, or I think very amenable to peer pressure and information. And then there are some people who are clamoring and trying to get vaccines and having lots of trouble getting it. And I think that's a really important part of the story as well. And all of these have ethical implications. I put changes here because there was a really very interesting paper in the New England Journal this week, actually, called The Last Mile Logistics of Vaccine. And they quoted in that paper a recent study by Prescani of 66,800 US citizens, where the willingness to take a vaccine in October was 39%, and the willingness in January was 64%. So that's encouraging news that the numbers are changing in terms of willingness. They did see, however, differences by race and ethnicity, and education and age, and they also saw differences by perceived benefits and risks and access to information. So one of the things that's really important in thinking about acceptability is to try to understand the reasons for unwillingness. Certainly there are data to suggest that some people are concerned about the speed with which the vaccines were developed, which is why I took the time to say, despite the speed with which these vaccines came to be able to be distributed in the United States, the process was very similar to other processes that have preceded other vaccines. But there's some unfortunate information out there. I actually personally believe that the title Operation Warp Speed is an unfortunate choice of words, because it's confuses people about whether speed was the driving force and not quality and rigor. There's been a lot of politicization about the vaccines, and a lot of concern about pressure from different parts of the political regime, but also from companies and from other stakeholders in the process. And that has gotten a lot of attention in the press, even though I think there's, again, evidence to suggest that despite a lot of attention, there wasn't political pressure that influenced the development or approval of these, or authorization of these vaccines. I think there's plenty of data to suggest that people are not clear about the process and not about the data either, and don't understand actually what these vaccines can do and what they can't do. And some of that is also complicated by the fact that we're still learning. We're still learning about these vaccines. There is a lot of misinformation, as I already said. There are peer pressures. That I think some of the data that's come out from nursing home staff who have declined vaccines suggests that there's a lot of influence from their peers, because in nursing homes where more senior people are willing to take vaccines and where some of the peers are taking vaccines, the numbers of people who accept the vaccine are much higher. And I think overlying all of this is this worry about trust. We have, a backdrop of mixed views on trust of research, on mixed views on trust of government, and on trust of the medical establishment and scientists, et cetera. So I think all of that suggests that in terms of acceptability, part of the strategy for increasing it is working on strategies that increase our level of trust. So I'm going to stop there and turn it over to my colleague, Kathy Kinlaw, who's going to talk about other important parts of this process.
Wonderful. That was a great introduction for all of us, Christine. Thank you. So I'm going to hopefully share my screen. And hope you can see that okay. All right. So I have had the pleasure of being involved both at sort of a local level in the Georgia arena, but also in a national level, both with some of the early issues that Christine's aware of as well related to allocation within healthcare systems and what kind of planning needed to be done in case we ran out of scarce critical care resources. And then we moved to this arena where vaccine questions have really been a powerful part of our conversation in recent months. And one of the groups that I've had a chance to be a part of is the vaccines work group for COVID-19 for a group that many of you may know called the Advisory Committee on Immunization Practice. So the ACIP, as it is called, is a group of 15 individuals who are the members who actually vote. A number of other people join them on their regular meetings. But this group is actually charged with making recommendations to the director of CDC about which vaccines should be considered and approved, and also other practices around vaccination, which we'll talk about. So our work group has met every week since the spring, and the goals or the responsibilities that we have are several. One is to actually propose vaccine allocation. So the idea of who will be in each phase or tier for receiving the vaccine. That's a charge for our work group. And then to review actually each vaccine candidate that comes up for consideration. And so we're looking at all of the phase trials and looking at all the data along the way to try to make sure we are up to date with the evidence to date. And then to propose recommendations for consideration by the full ACIP about vaccine authorization. So that's the role that I've been deeply involved in, and again, a privilege to do so. So the pathway, we've already heard about the pathway for vaccine development. The further pathway from that is that the ACIP work group, as I said, is reviewing the vaccine trial date on a regular basis, and then is coming forward with policy recommendations for the ACIP. So this is happening sort of parallel to the vaccine production and trial process. And then the pharmaceutical company, as we've just heard, applies to the FDA for emergency use authorization to date. And then at that point, when the authorization occurs, the ACIP actually reviews and votes on recommendations about that particular vaccine and about prioritization to various groups of the vaccine. And that goes forward to the CDC director for review and publication and availability to all of the states. So one of the things that the ACIP work group that I'm on has had a chance to do this year amidst all of the rapidity of the sort of addressing COVID-19 was to actually decide that we were going to make ethical principles a very clear, explicit part of our decision-making process for allocating initial supplies of the vaccine. And I'm so pleased that this full group was very much behind this. And so I want to make sure that you are aware of the 4 principles that kind of have guided much of our work. The first is on maximizing benefits and minimizing harms. And so very much based on a concept of respect and care for individuals receiving the vaccines and using the very best available evidence to date in our process, and then to promote, of course, public health, so the health of all of us across the country, in terms of the United States. And of course, we're all thinking globally as well these days. And then also, though, to minimize severe illness and death. So that kind of proportionality of thinking has been important. And then also, though, to really make a statement about mitigating health inequities. So trying to reduce the burden of the COVID-19 disease on particular populations where there are existing health disparities has been a part of the vision of our group, and an opportunity for all to be healthy. Closely related to that is promoting justice. So hoping to treat all of the affected groups and communities fairly, and to, again, remove unjust barriers to COVID-19 vaccination. And I think we're all sort of living that out right now. And I'll talk a little bit more about the distribution and allocation pathways in a moment and the ethical questions there. And then underwriting all of this, the idea of promoting transparency. So trying to provide clear, understandable information that's open to public participation and review, and to the degree possible to include the public in the process of decision-making along the way. And one thing that we often try to do in ethics is to make sure we have community or stakeholder engagement, so that we're having focus groups and other ways in which we're getting input. And I'll say that there's been some work in that arena, probably not as much as most of us would have liked, given the rapidity of the movement of the virus, but I think that's an important commitment as well. And so in our trying to determine, so the ordering or the phasing of who would actually get the initial doses of the vaccine, we certainly are following this principle of maximizing benefit and minimizing harm, and really kind of targeting what are our hoped outcomes to reduce COVID-19 infection, but also look at severity of disease, including hospitalization and death. And then also to be aware that in our decision-making, we need to take into account the preservation of certain services that seem to be essential to not only the COVID-19 response. We see that reflected in our first tier of who's receiving the vaccine, but also how do we make sure that society is able to continue to function along the way. So our recommendations for the initial recipients of the 1A recipients of the COVID-19 vaccine are based, of course, on some operating realities at the time. One was the expectation that the demand for the vaccine would exceed the supply, at least initially. So in other words, we would not have enough vaccine available, and some groups would have to have higher priority while those vaccine doses were limited. And then that we were very much looking at the scientific evidence to date. So one of the roles of CDC at large has been to be providing a lot of the information on epidemiology. We're also looking at the vaccine trials information to try to understand as much as possible about what we're learning about the virus and the ability to develop some immunity to that. So that's been a very important part of the work group process. In doing so, we had marvelous folks, experts working on modeling both allocation pathways based on the scientific evidence, and then what would the impact of various allocation pathways be if we had a particular population that we wanted to provide the vaccine to early. What's the likelihood of that affecting folks who are vulnerable and at risk, and also perhaps at least reducing the amount of transmission of the virus across other populations. And then, of course, we looked at the ethical principles also. We actually had a very active framework for applying the principles for real-time use. And so I think many of us are familiar with the recommended phases of the vaccine rollout now, but just to make sure, so the 1A is inclusive of healthcare personnel, and these are really any individuals who are involved in frontline care of patients. We're not talking about just physicians and nurses and respiratory therapists, but we're talking about people who are patient transporters, or who are people who are cleaning rooms where patients have been, who have COVID. So anyone who is likely to have had an increased risk of exposure. And then also long-term care facility residents. So we certainly have seen the impact on the long-term care community and wanted to be responsive to that. There's certainly a vulnerable and at-risk population. And then other tiers following. And so frontline essential workers, that is often included firefighters, police, and other responders. And then persons aged 75 and above, noting that the vulnerability of older individuals has been clear as we've learned more about the COVID virus. And then other groups, as you see listed below. So this was the pathway that we initially reported to ACIP, and ACIP has recommended for implementation. So next steps then, we're actually reviewing every vaccine candidate, every product that comes forward, and that has been submitted to FDA, and ones that we think might be coming up as well. And once ACIP makes its recommendation and the CDC director approves, then of course we're moving into a new phase, which we're very much in now with interesting ethical questions arising. So there have been a tremendous amount of variation in state plans, moving away from some of the CDC recommendations, and variation in the effective administration of the vaccine that I want to spend a few minutes talking about with you. So most of you may know, but there is a COVID data tracker that CDC puts out, and this is the link here, and in a few minutes I'll actually put it in our chat if I can do that. But you can see that vaccinations in the United States is one of the things that can be tracked. And so we see the number of doses that have been distributed and the total number of doses that have been administered across the United States by looking at this information. I will say, in my experience, when I compare it to state reports, this data tracker is probably lagging a little bit behind. But we can see, for example, on this site that this is a reflection of the amount of doses distributed by state per 100,000 people living in the state. And as you might expect, in general, the doses that have been received by the states are relatively equivalent per 100,000. And then we're looking to the states to move forward with the distribution of those doses. And so just pulling up Missouri, for example, and this is again on the same CDC site, we see the total number of distributed doses. And I'm going to look at my second monitor for a second just to make sure I can reflect this well. So about 46% of the doses that have been distributed have been administered, about 382,000 in Missouri, according to this site. Gives you an idea of where you are in comparison with other states, those of you who are Missouri folks. But I also will say that if you look at your own state reports, again, I think there's a little bit of a lag on the CDC site. There are actually a slight increase in the numbers of individuals who have received at least a first dose according to the Missouri website. So we have to compare those along the way. I'll also say that this is a good place to think together a little bit about how different states are handling the distribution. So Missouri, if you go to the website listed on the slide, you'll see that not only has phase 1A been implemented, but also phase 1B, both tiers 1 and 2 in Missouri. And that phasing looks certainly parallels CDC in many ways, but also has some much more specific groups or communities involved in the various phases. It does include the long-term care facility residents and staff and healthcare workers that CDC's tiering included, but also then moved forward with EMS, EMT, and paramedics. And then again, because you're already in phase 1B, includes first responders and emergency responders, and then high-risk individuals in tier 1 and tier 2 of phase 1B. If I look at Georgia, which is where I am at Emory, Georgia also veered from CDC. So several weeks ago, the decision was made to add to phase 1A in Georgia a couple of other categories. So they moved toward adults age 65 and older more quickly than the CDC initial guidance indicated, and also some of the law enforcement, firefighters, et cetera. So again, it's of note what kind of state variation we're seeing. This week I had a chance to speak to directors of centers who cared for individuals with intellectual and developmental disabilities. And so looked just briefly at some of the reports about vaccine prioritization of these individuals. And again, without walking through all of this, you can see there's a lot of variation between states in where people living with disabilities are actually included in various phases. So a lot of variation has occurred for us. And then just a quick snapshot, again, I'll show you Georgia as an example. In terms of actual vaccines administered, we've seen quite a variation across our state. And so on January 6th, so somewhat early in the distribution in our state, we had about 24% of the vaccines that had been received in Georgia that had been administered. So, you know, fairly low, if you will. And then a couple of weeks after that, on the 21st, we were glad to see our vaccine administration rates had increased. We were at about 52% at that time. And then furthermore, this week, we've moved up to about almost 60% of our vaccines have been administered. So one of the things that we are all looking at is why the administration or the distribution and administration has been slower than we had all anticipated. Christine referred briefly to surveys, and there are surveys nationally, but also in many cases surveys in local communities or surveys of healthcare systems to look at the likelihood of those communities actually taking the vaccine. And we are seeing a lot of vaccine hesitancy in various communities, including in healthcare personnel, as Christine said. And that has certainly made a difference in terms of what we anticipated would be perhaps a more rapid rollout of the vaccine. Not that we weren't aware that there would be vaccine hesitancy, because we have heard about this all during the COVID-19 pandemic. Would you be prepared to take a vaccine if it's available? That has been increasing in percentage, as was noted earlier, but still a fair amount of vaccine hesitancy in the community. And I'm happy to talk more about that, you know, later after my remarks as well. But I would like to say, I think the important distinction between misinformation and disinformation may be helpful as we think about vaccine hesitancy. And so misinformation is where information is spread that is false information, but the one who's actually spreading it believes it to be true. So there's not a sort of a bad intent here, but there's a passing along of information that is not accurate. Whereas disinformation is false information that one spreads even though they know it to be false. And so I think really important to think about when information is being spread, what is the nature of that information, and are there ways to approach people who may be hesitant because they're receiving information that is informed by whether the information was misinformation or disinformation. And also, of course, we want to acknowledge the very real historical examples of atrocities for receipt of medications and being in research trials that a number of communities have experienced, that is very much leading in an understandable way to hesitancy to take the vaccine or refusal to take the vaccine. So how we think about all of these factors, I think, is important. I'll note that in some ways, I think it's felt like we've been building the plane while we're flying it all through the COVID-19 virus. So again, the confusion and that the way in which that has impacted vaccine distribution to the states, and even then within the states to various communities, has been a part of that process. So even though there was a lot of planning that went into it, We're seeing that vaccine rollout again did not occur as we had hoped, as quickly as we had hoped. So various degrees of following the CDC guidelines, diversity of state plans does raise some interesting questions for all of us. The vaccine administration really was, as I said, much slower than expected. We had, of course, expected that demand would outweigh supply, but for a while, we were in a period where people were not either able to receive it or who were hesitant to receive it. And we actually had more supply in some communities than people were taking it. And so it raised some important questions about how do we make sure it's getting to communities who are actually willing to take the vaccine. And we, of course, did not want to be wasting the vaccine. And that issue really does continue. I think in particular communities, we're watching people try to react to starting to utilize doses or vials of the vaccine and being worried whether they'll have vaccine at the end of the day, that there's no one there to take. And so can we come up with other pathways to administering that vaccine so we're not wasting it at all? And then again, the various plans that have evolved have raised questions about fairness and consistency in the way in which people are able to receive the vaccine. There's been difficulty in implementing essential worker prioritization. So further phases of the vaccine do call for bringing essential workers into the picture. And of course, healthcare personnel have been one type of frontline essential worker. But when we talk about other categories, say perhaps individuals who are unable to work remotely, so they're having to go into work and it's very difficult for them to be 6 feet apart from the public they're serving. So whether we're talking about grocery store workers or people who are delivering packages or any of the other folks who have become essential for many parts of society, how are we going to be able to identify that those people are able to now move into receiving vaccine? There's been some discussion of use of frameworks like the Social Vulnerability Index, which is a CDC index that tries to look at zip code and community specific areas to where there are a number of factors that may make an individual more vulnerable to the virus. And could we in some way utilize that in terms of trying to make sure that those individuals are receiving the vaccine? And very much in the midst of recognizing the disproportionate impact of COVID-19 on certain populations and certain communities. And so the question of whether there's a potential to respond in the allocation process itself and in the distribution process to that disproportionate impact, that raises questions again of prioritization, but also of making sure there's access in particular communities to the vaccine as it rolls out. This has also been a period and continues to be a period, of course, of evolving knowledge. So there's been a lot of lack of knowledge along the way, right? So we had a lot of building knowledge about the vaccine trials. We continue to learn. So even with the emergency use authorization, there's a new phase now of learning from those vaccine trials. And as the vaccines are administered, the opportunity to continue to learn about the vaccines and about the impact on the virus. We're learning about the virus along the way as well, but much of this has been done in an atmosphere of uncertainty. And as information continues to evolve, we're looking at some sort of big questions. For example, we know about the efficacy and safety of the Pfizer and Moderna vaccines from the trial data. One of the endpoints that wasn't looked at was the ability for someone who has been vaccinated, would they have the ability still to transmit the disease to others? And so that was not an endpoint of the study and something that is being looked at, of course, very closely now, so that we hope that we can avoid further transmission as more and more people are vaccinated, but we don't know that. Implications for children have shifted. I just was talking to some pediatric fellows about this. So early in the virus, we were very happy that children did not seem to be as affected by the virus as adults. but we're seeing some shifts in the number of children who are being affected now. We don't know what the variants will look like there. And we're also seeing children who have developed COVID-19 who have some long-term syndromes that are being looked at more closely. In adults, we're also seeing what's now called a long COVID syndrome. So people who have moved through the COVID phase, but also are dealing with ongoing symptoms. We need to learn more about that. And then, of course, much of the safety data for pregnant women and breastfeeding women, for example, were not included in the Pfizer and Moderna trials. So we're learning about that and the variants of the virus as well, as Christine said. So this is a period of how do we make decisions and ethically thoughtful, fair decisions in the midst of evolving knowledge. So I think I'll give you another slide maybe, and then I'll stop for now. But I do want to say within our healthcare systems, of course, many of the things that we've been talking about that impact the state level, of course, are also impacting us at a healthcare system level, where there's continued need for effective communication. And also, let me just say, we're hearing all about this, but in our communities and even within our healthcare systems, making sure we have mechanisms for scheduling that are accessible to everyone and understandable, and helping people negotiate how to schedule the appointments. We need to make sure we're thinking about access to vaccination administration sites, particularly in communities for whom it may be difficult to go to centralized locations. Within healthcare, we've also talked about staggering vaccine administration within units, so that if there were any reactions for either site injections or systemic reactions for healthcare personnel, that not everybody in a particular unit or floor would be potentially out for a day or two. And then it's really brought a good legacy, I think, of sharing information between healthcare systems as we move this forward. So I'm going to stop with that, and let me stop sharing so we can move forward. Thanks so very much.
Well, that was great. Really fantastic information. Thank you both so much for sharing your insights with us. We have been receiving some questions, and there are a few that I think would be very good to speak about live, or at least answer live. But before we get to that, I'd like to go back maybe just a few slides. We don't have to put them up, and talk about what you just mentioned, Kathy. And that has to do with understanding the social and cultural aspects of different communities as it relates to vaccines. I know at our university, at Kansas City University, we're doing listening tours in our communities of color and underrepresented minority communities, so that we can better enhance the information that they need to not be worried about these vaccines. Can you talk a little bit about completing that circle and what's important about getting the information, but then also in a very ethical way, providing the information necessary?
Yes, I am so glad that you all have made that commitment to reaching out to particular communities. And I think that we need to do much more of that. As I mentioned briefly, there's been some level of community engagement to date. CDC did, I think, 49 or 50 focus groups across the United States over the last year. And anything we can learn from particular communities will be very important. And I think it's both making sure the misinformation, disinformation is understood and addressed, but also just listening. I mean, really deeply listening to learn what are the hesitancy, sources of hesitancy, how do we take those seriously? And I would say some of the things I'm extremely committed to, and this is from prior work, but certainly during COVID-19 as well, is this idea of when encountering someone who has questions or concerns, that we acknowledge those concerns, that we are not trying to dismiss them or even change their minds. We are really listening to what is at stake for this person, what's the value behind this, and acknowledging it and listening. And then, of course, being prepared to offer information if it is something the person wishes. But it just strikes me that when a person or a community is willing to be in conversation with us, they are indicating some level of openness to and trust in us, and that establishing that kind of relationship over the long term is much more valuable than trying to change minds, particularly. And so I think evolving that together will be powerful. And I do think we need to be particularly in conversations with communities that have been disproportionately impacted by this virus. You know, so again, my kudos to you all, and I hope there's replication of processes like that in many states.
Thank you. Christine, anything to add to that?
I agree with Kathy that one of the most important things is to listen. I had somebody ask me the other day, when you encounter somebody who's has either misinformation or disinformation and doesn't want to have a vaccine, what is the elevator speech? That was the question for me. And I said, first of all, I think that the best approach is to not try to solve it on the elevator unless it's a really long elevator ride, because it seems like the right thing to start with is to understand where the person's concerns are, what concerns they have, why they think that, where they found out that information, and try to the extent that they're willing to accept it, as Kathy said, give them access to information that you think is more accurate. So that, I think that's the right way to go.
Yeah, and if we think along the lines that if one person is asking a question, many people have the same question.
Sure.
And so it's important to distribute and make it available. We have another question that can go to both Christine and Kathy. This one has to do with personal responsibility and individuals that may be deferring their vaccination, even though they fall into a phased group at that particular time, to help out others, first-line workers or more vulnerable populations, feeling that taking that vaccine might actually be taking it away from somebody else who might need it. So how do we address that with certain individuals, even if they have vulnerabilities and morbidities that we have to be concerned about, but are deferring these vaccines?
Kathy, you want to go first?
Why don't you go first? Yeah.
I mean, I have some views about this. I think I've encountered this among some healthcare workers who I think understandably think, you know, in the work that I do, even though I'm a healthcare provider, I'm not as at high risk as some other people might be, and they should get the vaccine first. And my response is, you know, there is so there are people who are trying to jump the line and cheat. That's for sure. There are those people. But for the most part, there is a structure, and as Kathy laid out, a sort of very thoughtful process of who should go first, basically. And so if you're in a group that's being offered the vaccine because you're in that hierarchy, my view is you should take it. And you should take it for two reasons. One is because it's important for us to get as many people vaccinated as possible. Second, there is a sort of priority scheme that you fall into and you're being offered a vaccine. And as Kathy mentioned, you know, one of the things we don't want to happen is at the end of the day in a given vaccine clinic to have doses left over that nobody wants. And we certainly don't want to waste any of those. And I think the third thing I would say is, you know, even though there probably are people in some place that are at higher risk than you, there might be, there's no guarantee that you refusing this vaccine is going to make sure that they get it. And so for the other reasons, it's better to just take the vaccine and then, you know, work with the system to try to make sure that as many people get vaccinated as possible. That's my perspective.
I love what you said, Christine. I think that these are all really important components of helping people think through this. And it's interesting because I've had some, I'm sure this is happening for all of us, but some people contact me directly, like, I think I shouldn't get this, you know, and people I don't even know. And part of it, I think, is they're sort of trying to be very thoughtful about where they're positioned and wanting others who they think about as being more vulnerable or at risk to have access. And so, as Christina said, that may or may not be a direct line to helping that particular population. But I do believe that, you know, there's every reason for people who are already in the correct tier, if you will, the right tier that's ready for vaccination, to be a part of the process of both demonstrating to other colleagues, but also to going ahead and gaining protection so that they can do the work that they've been asked to do. So we're talking about healthcare personnel, for example. Those are individuals who are needed to take care of others and to make sure that we have a good COVID-19 response. And there's a lot of pressure in healthcare right now to make sure that we do have enough personnel available to us. A lot of staff are weary, and of course, many have had the virus. It's interesting, some of my healthcare colleagues will say, but you know, when I'm at work, I have adequate PPE and I think I'm protected. But we're also seeing that you know, people bring it in when they're, you know, from being outside of work, and or maybe are in a break room, and you know, that's where some of the transmission may occur. So it's not as if that in and of itself is reason enough for a healthcare personnel to say, let me defer this to someone else because I have PPE. They're still at risk in other spaces.
Yeah.
Great, thank you. Yeah, another question came through talking about truth, trust, and transparency, and you both mentioned the word trust in your talks, but transparency seems to be a double-edged sword, and we have seen in media and even in conversations, I'm sure many of us have heard that the transparency is actually being used to, in some cases, maybe even as a weapon against the CDC or the NIH, maybe even claims like they don't really know what's going on because things change all the time. And how do you address that? Because transparency is a tool that we're using to aid communication, but it's also very easy to have it impact our trust and create maybe distruth or a lack of understanding.
Yeah, I can see both of the sort of perspectives there. And, you know, I mean, as an ethicist, I feel very strongly about our willingness and ability to talk about what we know and also to talk about what we don't know. I think there's power in that. It's important for all of us to understand that there is uncertainty in this environment. And so we don't want to be indicating knowledge where knowledge does not exist. We don't want that to be alarmist in any way. You know, it's not for that purpose. So again, how we say it and the information we provide, and how we communicate, how we message that, I think is important. So we're not alarmist. But we also need to let people know that this knowledge base is evolving and there are things that are being worked on. This is what's being done in light of the fact that we don't know everything at this point. And, you know, I find that bringing people with us there tends to engender trust, not making false claims about things that we simply don't know yet. But making sure that we're letting people know we're going to continue to keep you in the loop, right? We want to hear from you. We want you to ask us hard questions, and we will continue to bring you the information along the way. We really will, right? Not just saying it, but that we do so.
I agree. I mean, I think we are in a situation where information changes, and it's going to keep changing. I mean, this is a year ago, we didn't know anything about this. What we know now, a year later, is quite remarkable. But think about all of the points along the way that information changed or evolved, or we knew more, or we understood something better, or some recommendation changed. I agree with Kathy. I think that transparency is the key to trust, actually, that people aren't going to trust information they can't find, or information that if things keep changing and they don't understand why. I think transparency is absolutely key. And it doesn't preclude, of course, criticism. And the questioner sort of said, claims that the CDC or the NIH didn't know what they were doing. Well, maybe those claims aren't completely accurate, but it is also true that the CDC and the NIH were learning along with everybody else, as time went on and as information was available and as data emerged and as things were tried. And so that kind of information from those agencies to be as transparent as possible is also critical, I think, for trust. And we've made mistakes. We are going to make mistakes, but we're going to have to learn from those mistakes and try to do the best we can. And to be honest about that, I think, is really the best way to get people's trust.
Thank you. I think one of the other questions that did come up that I think would be good to talk about live also talks about authorization versus approval, and how those two terms tend to lead down a path, but each path is not necessarily overlapping in all places. Yeah. This will actually get to one of the other questions that came through, which is, how do we go now from an EUA to fully approved vaccine, since all this data is coming in and it's still being evaluated? And I think we could probably combine the answers to that. So I'll throw that out to both of you.
Yeah. I actually think it goes along with the question of transparency. I think it is useful and honest to make a distinction between authorization and approval, because they aren't the same. And under authorization, we are going to learn more things as we go along. New vaccine candidates are going to be authorized. There's going to be lots of data to try to sort through. And, presumably many, if not all, of the vaccines that are widely distributed under authorization will ultimately be approved, but that hasn't happened yet. I was struck, for example, I did get my first dose of the vaccine the other day, and I was struck, for example, by the information I was given when I was getting my vaccine, which basically said, this vaccine is still experimental. And I thought, that's an interesting way to describe it. I mean, I certainly, under authorization, it is not an approved vaccine, so I think technically that's correct. But I think, distinguishing between the two in terms of what we know and what we don't know is probably an honest way to present information. But it has to be done in a way that doesn't confuse people, I think. That's the part that's a little more challenging. And I think, as you said, what needs to be done to get to approval? I don't know this for fact, but I would guess that the companies that have authorized vaccines are putting their packages together for a BLA to get approval. And if they have sufficient amount of data, and they will be collecting more data, they are collecting more data. For example, one of the things that I know that at least Pfizer is running a study of children. So, in order to try to understand the safety of their vaccine in children is very important data to final approval of the vaccine. And so there are studies going on looking at children. Now, at the moment, my understanding is that they're only looking at children from the ages of 12 to 16. But if they find safety in that age group, and comparable immune responses, then the plan, I believe, is to de-escalate by age so that they will study younger children, so that ultimately, when we have an approved vaccine, we will know we can use it in every age. And so there are differences that are important in terms of authorization and approval.
I think Christine is spot on. I think as she said earlier, it's important to be able to communicate that all of the phases for the authorization, are mirroring the process for approval as well, so that people are aware that there's a lot of comprehensive work that brought us to the emergency use authorization. So I think that's one message that can be helpful, and that we will have, as you just said, Christine, a lot more information that will allow us to move toward the full approval process, at least. And that is exactly what I think the public's looking for, right? Provide us with more information about efficacy, about safety, about reactogenicity at the, in terms of when you receive the vaccine. All of that is going to be powerful for the country and for individuals who are thinking about receiving the vaccine, in addition to allowing us to move to a full approval process.
Thank you. We do have another question that's related to part of it, to the listening tour we just talked about, but also to the acceptance of some of the failures early on in the pandemic and how we responded, particularly in vulnerable populations. Things like PPE distribution and testing and tracing of spread and infection. Do you think these failures push us or obligate us to do more on the vaccine front for these populations that have been failed in the past? Or are these part of the entire plan, these failures part of the entire plan to do better for everybody?
Great question. So I think, again, as a part of transparency, our being as clear as possible about where things did not go well. And, even in my few slides, talking about, our distribution efforts, what kind of planning was in place. And there was a lot of planning going on. It wasn't that it was omitted in some way, but they fell short. And so, are we doing the root cause analysis to look at how that happened, what did we not anticipate, what did we not respond to? And that same principle is true in populations and communities that feel that that were underserved at various points. I think that's important that we do. And I will say, so this is an obligation throughout the entire process where we need to continue. I will say, and this has been a really big part of the conversation for many of us working in ethics, both in terms of vaccine, but also for availability of critical care resources in particular communities where those resources are becoming more scarce as we see the increased hospitalizations and serious illness. At the point of vaccine allocation or at the point of providing a particular critical care resource, is that the point at which we could also perhaps do something that would acknowledge that there are communities that have been disproportionately impacted? And frankly, I think everyone is struggling with that. It raises fundamental questions such as, is that feasible, right? Is that really possible to do? What would it look like to do that well? How would it be implemented? Can we, we can't reverse a whole history of inaccessible health care and disproportionate and unjust decisions in the past at one particular decision point. But I really do believe there are a lot of states and there are a lot of particular healthcare systems that are looking at those kinds of issues right now. And so I say kudos to our trying to look at pathways for addressing this, but it is quite complex and it will not be simple.
I just want to add one little thing. I agree with Kathy. I think the question about, are there things we can do with respect to the vaccine that might address some of the more vulnerable populations? And I think actually Kathy had in some of her slides, one of the things that struck me as very important, but not always at the top of our minds when we put structures together is, there are people who are vulnerable to COVID who are disadvantaged in terms of scheduling vaccines or having access to vaccine sites or even knowing that they're eligible for a vaccine slot. So finding ways to reach those people and make sure that they have accessible scheduling options. I mean, the classic example, which I've heard many people talk about, 88-year-old woman who doesn't know how to use a computer and it's impossible to get on a computer to, you know, schedule an appointment. Or a person who is, you know, an environmental services person in a facility who doesn't have email or doesn't have, you know, electronic device or whatever. I mean, there are lots of interesting examples of that, and we should be very cognizant of trying to reach people who are at risk in line for vaccines, but aren't able to get the information, or aren't able to, as Kathy said too, the disability community, get into the site, or don't have cars and drive through sites. I mean, there's so many examples of that. So that's one way we could use vaccines to address this issue.
If I totally agree. Sorry, if I can just add, you know, I think that we are talking about what I would call procedural ethics. So in addition to the substantive content of what is the right thing to do, you know, what are the processes that we put into place that make it possible for these commitments to be actually implemented and honored? And they're just as important on so many levels. That we think about accessibility, we think about where our distribution sites are for vaccine in particular communities, and have we actually worked with the community to talk about where that should be? And I know they're cold storage issues, but you know, where should that be? And what is the messaging, and who could provide the messaging, and how do we do that together? What resources are needed in local communities, particularly in disproportionately affected communities? So all of that is just so important. So I'm glad that Christine mentioned it also. And I'll say that, for example, in a healthcare system level, I've seen some great models of, you know, they have people who are, you may be vaccine champions, but they're not just going around talking about it. They're actually spending time in units who request it with individuals who are having trouble actually doing the scheduling, right? They're you know, one-on-one, fully PPE, but one-on-one, working with people to make sure they can schedule their vaccine, and making sure that there's local administration sites near the healthcare system for those individuals, or within the healthcare system. So there are a lot of things we're learning. There's a lot of innovation going on, and we need to be capturing that and sharing that with others.
Mm-hmm.
We are certainly developing some new best practices for delivering things. You know, we're in a situation that we don't experience on a yearly basis. So as we're building this airplane, as it's taking off, we're also learning things that are going to keep us flying for a long time. I have a question that's related to the two aspects of both vaccines and PPE. There is generally a confusion when we're discussing vaccines, and they are going to be the panacea to fix everything, when in reality, vaccines don't prevent infection, they prevent disease. What prevents infection is the use of PPE appropriately. And so it's that two-pronged approach that allows us to be successful. It's never been more evident than if you look at the number of infections for flu this year, because both of those aspects are being attacked. We have the lowest count of flu ever in the history of flu, and it's because we're mitigating for COVID, but also giving flu vaccines. So the ethical dilemma that I see is people saying, well, I have the vaccine now, and now I can go travel, or now I don't have to wear my mask, or, you know what, I can downgrade this, and we're going to start going out to restaurants and bars because I haven't done it in 10 months, and now that I have the vaccine, I can do it. Can you both comment on those issues?
I'll make a brief comment and turn it to Christine, but yes, I think, thank you for bringing that up, because, and we're all hearing this message that once you get the vaccine, you still must mask, and you still must socially distance, and all of the other precautions. And I think we must do that. I mean, if we are moving forward with more and more adequate administration of the vaccine, it will potentially make a huge difference. But this too is a part of that process, is continuing to do all of these other behaviors that will minimize any potential risk for transmission, I think is extraordinarily, you know, important. And we want to make sure that that message is loud and clear to folks, that we don't just simply think that everything's been resolved and that we can be actors in ways that we would like to. And so I think, you know, the power of making sure that people understand this is the way in which we move forward as a group. This is a common good question. This is about the public good at large, and we're making a commitment to continuing, you know, these behaviors for the foreseeable future, right? And a part of this, of course, is the variants. We don't know enough about the viral variants yet to make claims about the vaccines we currently are receiving being able to be as protective as they were for the original virus. And so again, we're just in a period of uncertainty where we need people to make commitments to others by continuing those measures.
Yeah. I would just add one thing. I think this is a great example of both the ethical decision points that happen in research and the value of research. And the reason I say that is for two reasons. One is, as you said, Dr. D'Agostino, the primary endpoint of the vaccine trials that have been done is symptomatic disease. So they were not set up to determine whether or not people got infected, but also importantly, whether or not they could still transmit virus. So as somebody might have said before, you know, the vaccines are very effective at preventing symptomatic disease and serious disease, both of which are really important pieces of information. We want to prevent disease and we want to prevent serious disease. We do not yet know whether or not the vaccine has an impact on transmission. And until the research is done to get that answer, the need to continue to wear masks and not travel and follow public health measures is important, because I might be protected from getting disease, but I might still be able to transmit the virus to people I come into contact with. But with research, we're going to get the answer to that question. I mean, there's research going on right now trying to figure it out. And I think, you know, the same way with the variants, you know, we know certain things about protecting against disease and severe disease now based on the circulating virus that the vaccines were based on. As the variants come in, we're going to have to do research to figure out whether or not the vaccines will protect against these variants. And the sort of ironic thing is the best way to protect against variants is to get everybody vaccinated, because the more people the less virus there is circulating around, the less likelihood there is that there will be mutated virus.
Absolutely, and that is one of the most amazing things about these mRNA vaccines. They can be manipulated and changed based on mutation patterns very rapidly. Mm-hmm. So that can be a positive. But your last point, I really want to emphasize, and that is the more vaccine that's out there, the less replication of virus there is, the less mutation that occurs. And this is what's critical about what we're doing. We just had a question come in, and maybe we can address this quickly. I know we only have a few minutes left, but I think it's important. And the question is really, why can't we use social vulnerability and area deprivation scales to show us exactly where the lack of resources exist within communities? And how do we use these tools? Should we be using these more ubiquitously? Are these things that should be laid out through the public health system versus universities versus general public? What are your thoughts on this?
I'll let Kathy answer that one.
Yeah, I think there's, of course, a body of information developing around both the Area Deprivation Index and the Social Vulnerability Index. And we're still learning in what ways can that be helpful. And so there have been, and there has been over COVID-19 pandemic, the period, the last 10 months or so, some particular states and some particular healthcare systems that are trying to say, hey, could we plug this in, and what difference would that make in terms of allocating critical care resources or providing vaccines? So we're beginning to think about that more carefully. I think it's very promising. I mean, the social vulnerability index includes about 15 different factors, and they're interestingly diverse. They're, you know, it's, do you live in a congregate setting where there are, you know, many people who might be affected, their poverty issues, education, transportation. There are many different factors that are quite promising. We don't know enough yet about their direct relevance, but I think they're very promising. And the idea, again, of helping us try to describe in rich ways particular communities for whom the vaccine may be very effective in a population that's been disproportionately impacted is there. So I'm hopeful that we'll see some work coming out in coming weeks and months about that. So it's something to, I think it's something that we must seriously take into account. And both of those indices are good ones, and there may be others also being innovated.
There's an interesting thing going on in Washington, D.C., which is where I live. It's a much blunter instrument. It's zip code. So among people over a certain age who are now being invited to sign up for vaccines, they are only opening up to certain zip codes, because those zip codes are communities where people have been disproportionately affected.
Yeah, and we are seeing unique uses of different pieces of information based on the state's distribution patterns. So that's true. I know we only have 3 minutes left, and I want to leave time for kudos and thank yous. But there is an outstanding question about how these vaccines are going to be used once they're released, once they're authorized, once anybody can get them. So they're no longer EUAs, and the use to allow people to do certain jobs. So healthcare workers, or will an employer mandate a COVID vaccine? This is a much broader question about all vaccines, but I was wondering if we can get just a few words on that.
I'll give you my 2 cents quickly and then leave it to Kathy to give you the real answer. I think there are some situations in which requiring vaccines makes sense. So for example, I am actually a supporter of the idea that healthcare institutions can require their employees to take the flu vaccine. I think this is another example, however, of why it's important to recognize the difference between emergency authorization and approval. I don't think we're ready for mandating COVID vaccines. We're still learning about COVID vaccines. We still have a lot to learn about COVID vaccines. And down the road, and I think the questioner maybe asked down the road, you know, it is possible at some point in the future that, especially if it's something that we have to get on a repeat basis, that there will be a requirement for COVID vaccine before you do certain jobs. But at this point, I don't think that we're ready.
Yeah, I agree with both of those comments, Christine. So it's not unlike, I remember the phase where there was consideration about mandating for healthcare personnel the flu vaccine, or whether a healthcare system could require that. And one of the things that I've seen systems do is actually do a lot of stakeholder engagement work there, focus groups across everybody who works in a healthcare system or across an industry, so that, again, you're acknowledging, you're hearing, you're trying to address. So I think that kind of work could be quite powerful when we get to the point where we know more about the vaccine and the virus. And also, of course, this is a virus in its current state, which has been much more severe in terms of morbidity, severity of illness, and death than the flu vaccine. So the idea of perhaps reaching a place, again, depending on the status of the virus and the vaccine at that point, it may be very important for us to make sure that, for example, healthcare systems are not a place where transmission would occur.
Great. Well, I know that's a much bigger topic. It's one that has been dealt with for many, many years, and there's more to come. I want to thank you both, Kathy Kinlaw, Christine Grady, for all of your information. This was wonderful on behalf of the Center for Practical Bioethics. This was a wonderful learning opportunity for us. I know in meeting you over the last few weeks and getting ready for this, I've learned so much from you, and I appreciate that. Please keep doing all the great work that you're doing, and we hope to see you soon. I'm going to pass this back to Matthew from the center, and we'll close this out.
Thank you very much.
Thanks for the invitation.
All right. Thank you, Darren, and our presenters, Christine and Kathy. Yeah, just to close us out, I'd like to let everyone know that we record these webinars, and you can find the recordings posted on our YouTube channel. So if you go to YouTube and search for Practical Bioethics, you'll find us there, along with all of our, we have a whole pandemic series that we did last year, and we'll have more content like this coming. And then also, this is actually the first installment in a multi-part series that we're doing on vaccine. And the next one I think is scheduled for March 5th. I'm not sure that we've distributed the sort of the promotional material for that yet, but keep an eye out for it. You'll be able to find information about that session on our events calendar, so practicalbioethics.org, and then you can find our events calendar there. And so, yeah, hopefully we'll see you on the next one. And thank you everyone for being on this one, and we will see you next time.
Thank you, Matthew.
Take care.
Bye. Bye, Kathy.